Okay, so the second section, talking about immobility, hazards of immobility, and just the bigger, broader goals of a wheelchair assessment. Okay, so what do I mean by immobility? I mean, literally, like it says, you're not moving. Think of somebody in a wheelchair like Arnold. They're not moving hardly at all. They're sitting all day long, and it's really, really hard on your body. The human body needs to, loves to move. Not moving, the body breaks down pretty quickly. Very drastic and extreme with somebody in a wheelchair all the time, or somebody in a hospital bed all the time. To a lesser degree, it affects us as well. Our lifestyle, we're sitting, you're probably sitting right now in front of your laptop watching this. We sit all day long. When we get into ergonomics in the fifth year, you'll see how this really does a number on all of our joints in our body. But more so as an OT, the people you're going to see in wheelchairs, see in hospital beds, they've been all day in a hospital bed for a surgery or an illness, they are really at high risk for a lot of different serious problems. Just going to list some of them. Respiratory system, sitting, being in a wheelchair in a hospital, laying down in a hospital bed, especially all day, can really compromise your lungs. Most people with spinal cord injuries, they die young. Why do they die young? Complications. What kind of complications? Complications from sitting all day. One of the biggest ones is pneumonia. They're sitting, things are pooling in their lungs. They don't have good expansion of their lungs. Lung volume is decreased, all these different things. Aspiration, which is choking. Very inefficient system if you're still all day. Gastrointestinal system, your bowels can really be affected if you're not moving much. Your muscles waste away, atrophy, this is a term we talked about earlier. They waste away, get really weak really quickly if you're not moving. You're losing 3 to 5% at least every day. I've heard even high numbers from not moving. Calcium from bone loss. Your bones stay strong through weight bearing. What do I mean by weight bearing? Standing up and walking, pounding away at a treadmill, or when you're running, or whatever it is. As long as you're weight bearing on your bones, it keeps your bones strong. If you're not weight bearing on your bones get brittle. You lose the calcium. Osteoporosis. There's so much more to risk for fracturing. It doesn't take anything to break their leg, to break their hip, to break their ribs, that sort of stuff. Circulatory system is definitely compromised. There's just no flow. What keeps your circulatory system moving, especially the venous blood coming back to your heart, is movement of the joints. And if there's no movement of the joints, everything is just pooling, drops your blood pressure. You're at a high risk with something called a DVT, which is a deep vein thrombosis, which are blood clots, basically blood clots in your legs. You may have heard of people that go on long flights. Say you're going to, China or Asia, and you're on a plane for 12 hours at a time. You're at a high risk for DVTs, for these clots in your legs. Why? Because you're not moving. Again, need to move to stay healthy. Even your bladders need to empty, need to keep flowing. Everything needs to keep flowing. And then mentally, psychologically, just being isolated in a hospital bed all day, stuck in a wheelchair, can't get up and do the things you're used to doing. You could see that toll on Arnold. Definitely he was an extreme. To be honest, not really necessarily a nice person, but it did what was dysfunction that made everything worse. Couldn't work again, couldn't feel like a full person again and do those roles that you're talking about in all your theory classes. Really does a number on you psychologically, being not even able to move and do what you want to be able to do. These are hazards from being in bed all day. These things happen quickly, at least within a day. It says 3 to 5 days, but even faster than that. Your bowels, you get constipated. Here's a good picture of the atrophy. This leg, get rid of that leg. This one's probably a nerve issue, but the atrophy happens fast. Again, your lungs are just not expanding fully. You catch pneumonia. If you're working with clients in the hospital around feeding kind of stuff, want them up to feed so they don't choke, so the food and everything doesn't lodge in their lungs, and that leads to pneumonia. And pneumonia for older folks, health compromised folks, like people with spinal cord injuries like Arnold, it's deadly. People die from pneumonia all the time. It's the biggest killer. You're really going to be super conscientious of that as a therapist. Really does a number on your circulatory system. You get orthostatic hypotension, which is your blood pressure just bottoms out. You stand up and you black out. You're going to watch this with clients. The clots we talked about, your kidneys, other things that get pretty involved around circulatory system that can be impacted with a lot of immobility. Another really big thing we're going to talk more in depth about when we get into this wheelchair sizing is your skin. Your skin is very, very vulnerable, especially older folks' skin, but even younger people's skin. If you're in a wheelchair all day, sitting all day, it's a lot of stress on your skin. It leads to breakdown, leads to sores. And again, you have that impaired circulatory system. So those sores lead to infections. All kinds of awful things can happen. You have to be super conscious as a therapist, padding, getting the right fit. This kind of shows you some of those spots where they're vulnerable for sitting in a wheelchair, for skin breakdown. See how it's potentially rubbing there, the foot, the back of the lower body, these different spots we're going to get more into. Pressure sores. We talked about a lot of weight bearing, osteoporosis, the calcium imbalance, contractures, all these terrible things can happen, again, with immobility. Positioning, this is a really cool graphic. These little dots, these are the spots where somebody is very vulnerable to get skin breakdown, pressure sores, infections. So you have to be really careful with that as you're sizing and padding the wheelchair, that they have the good cushion. They're not going to be rubbing, getting sore spots there. Talks about the ideal position for the pelvis. We'll get more into that, especially next week, the slight tilt there. Something called the 90-90 rule. You may have heard this around ergonomics. What do you mean by that? See, there's like a 90-degree angle between her thighs and her lower legs right there. With her elbow, another 90-degree angle. Her feet, 90-degree angles. This is the ideal position to reduce skin breakdown in the chair. So you're not all slouchy and all over the place. You're at these nice sharp angles. Head and neck nice and upright, lined up in neutral. This will give you an example. We're talking about a good fit versus a bad fit. This is the bad fit on top. And you'll see this a ton in nursing homes. Therapists, aides are generally short-staffed. They haven't got the time to run around and keep repositioning people. But it's not a good thing to be positioned like this in a wheelchair. Leads to skin breakdown, leads to pressure sores, leads to pneumonia, leads to all kinds of health complications. Just look how much better she looks down here. See how her neck is back in neutral, her elbows in good position, her lower legs. She's not 90-90, she's got her legs up, but she looks pretty good. She's back in the chair. This is what we want, this is what we don't want. Okay, so now shifting towards the wheelchair assessment. We talked about the hazards of immobility, get an idea of what it's like to be with a spinal cord injury in a wheelchair. You'll be doing this a ton as an OT, wheelchair assessments. You'll be always assessing how well your client fits in the wheelchair, even if you didn't design the chair for them. In some cases you will, though. They need a new chair, and they'll say to the OT, can you do a wheelchair assessment on Mabel and room whatever? She needs a new one. She just doesn't fit her old one anymore. Can you size it up and tell us what you think? This is kind of the things you need to do. This is what we're going to be doing for this wheelchair assignment in the lab this week, and all that sort of stuff. So what are your big picture goals? The patient's goals, what do they want first and foremost? When I say first and foremost, though, you're going to keep safety as well. It's kind of a balancing act. What they want and what's safe. For example, what Arnold wanted was to shoot with his sip and puff rifle. I didn't think it was safe, so I didn't go there in terms of a goal. You'll have clients that have dementia. They can't make good decisions, so you have to kind of make good decisions, not so much for them, but with their family, and have them kind of, this is what we're thinking because we're worried about this sort of stuff. So it's what they want, and it's safe. What is their pattern of use? What are they using it for? Are they sitting all day in front of the TV? Are they in the kitchen cooking? Are they going to work in it? What is their environment like? Is it outdoors, indoors, hard floors, rugs? What are they capable of physically? Can they push their wheelchair on their own? Do they have the mental capacity to use an electric wheelchair or not? Anthropometric, that's their body. What's their body type like? The body needs to fit the chair. Thinking about the 90-90 rule, the good fit. We'll get more into that. Future changes. What is the disease? If it's a spinal cord injury, this is what they're going to be like for the rest of their life. It's not going to change. Parkinson's disease, Lou Gehrig's ALS kind of thing, MS, they're probably going to get worse. So to kind of think about that, there's a good chance they may gain weight in it. So to kind of think about that. What are the resources? What kind of insurance do they have? Those sorts of things. Basically, it comes down to two big things. Protecting their skin through ideal alignment is kind of number one. And then their independence, mobility-wise, this is their mobility. This is their legs now, this wheelchair. Get them to do as much as they possibly can safely. So maximizing doing as much as they possibly can safely that they want to do, and protecting their skin. Those are the big two around your wheelchair assessments.